We have the final session of the final day. We've gone with the alliterative title of Data Deterioration and Dying, which is a fairly mixed bag of talks that we're going to be having from people. First up, I'd like to introduce John. He's asked me to introduce him just as John, but I'm going to elaborate a little more because there's lots of people called John, probably in this room. John is a nurse specialist at Canterbury DHB. He is my data god. Whenever I have a question that relates to early warning scores, I send John an email, and usually within 12 hours a beautiful graphic comes back that he has sourced from Canterbury's ever-increasing multi-million entry database, giving me a perfect answer that I can then use to go and shove in the face of someone who's objecting to something I'm about to do. So John has solved many, many arguments for me on my behalf, and I'm eternally grateful. John is here to talk about torturing large data sets.
Thank you very much, Alex, and thank you. That's a very nice introduction. It's nice to be described as somebody who's nice. I got described as being a porn star earlier on today, which is very good. Possibly something to do with my moustache, but there you are. So I'm here to talk to you about torturing large data sets. And to start off with, Alex asked a question earlier about Audit, and I can just quickly go over what area under the receiving operating curve is. I Googled it. And I found out that it's actually an extinct type of cow, which you used to find in the European plains. So there you go, Alex, you'll enjoy that. I think we need to understand that you can do anything that you want with data. This guy, Ronald Coase, he was an economist. He won a Nobel Prize in early 90s for his work in economics over his lifetime. And he basically turned around and said, you can prove anything with data. So I think we have to be really, really careful that we don't decide to just look at data until it gives us the answer that we want to get from it. Because what I understand is from data, it's huge amounts of it, and you end up with a massive forest of things in front of you. And when you want to look at a tree, you need to examine it really, really closely. And you need to make sure that it doesn't take you into areas where you don't want to go to, or it doesn't take you to areas that actually don't make any sense to anybody. Because what we should be doing is we should be using the data to benefit people rather than to benefit ourselves. So, yeah. I have a very, very, very large data set. We've got over 2.5 million vital signs now in Canterbury. We've got a digital vital signs system called Patient Track, where the MKM stand outside. Other vital signs systems are available to you, so I'm not going to be advertising them. But we're increasing by 100,000 per month. So by the end of the year, we're going to have 3 million. By the end of next year, we're going to have 4 million, and then it's going to carry on. But what do we do with this? So I'm just going to talk to you about a little journey that we've had over the last probably 4 months, because we introduced the NZUs in November 2017, and we've had it for a year. And after a year, we need to make sure that it's working and need to make sure that actually it's doing the job that we want it to do. So it's part of that whole maintenance and sustaining the NZUs itself. So we've got clinical governance, we've got audit, then you have to have a question, then you have to think about what all the bits and pieces around the question are, and then you do some analytics, and then you review, and then you kind of go back to the beginning again and ask that question again. And in the implementation, we do this, but then we need to carry on doing this all the time. So we've got a governance group, and we're very lucky. It's made up of doctors and nurses from lots of different disciplines. So we've got a really, really good neurosurgeon in there. We've got a fantastic person from general medicine. We've got people from our rural hospitals. We've got people from our rehab hospitals. We've got nurses. We've got our nurses at night team, and we've got ICU as well. So it's a group effort. It's not seen as being ICU formalising it and saying, do this. It's actually everybody saying, what can we benefit out of the NZUs? How does it benefit our patients? We meet 3 monthly, or as regularly as we need to. So recently we've been meeting weekly, and our meetings, and I think this is important again, is in a meeting you discuss the work you've done outside the meeting rather than doing the work inside the meeting. So that's been, so some of the members are here. Some of the members left earlier because they've probably seen what I'm talking about. We did our audit, and our quality safety marker meant that the people who we see, we don't see. So the people who we're supposed to respond to and we're supposed to recognise, so this person is unwell, so now I need to go and see them, we're seeing 50% of those people. So our audit shows that we're not doing a very good job with our NZEWS. And the problem is, I think, that that figure is probably grossly inflated because we audit ourselves as well. So I'm going to audit what I do. I'm going to make me look a little bit better, but not too good, which is why we've got to about 55%. Looking at them out there, my gut feeling is it's less than that. And it's a little bit disappointing. But seeing as I can see every single red zone, I'm not doing a retrospective audit of people who've met and met criteria or people who've been seen. I can see everybody, or we can see everybody, because it's all in a digital system. So we can audit everybody. And we can go up and say, oh, okay, well, what's going on with these people? And that's what we do with our audits, is we see all the people, rather than choosing the people who we go and see. So we had to ask this question of why is it that we're doing this? And I think it's really important, again, that we can have different ways of looking at data. So we've got structured data from our database, but then you need to involve lots of unstructured data as well. And unstructured data for me is going and talking to people, and for our team is going to talking to people and say, what is going on? And if you go and talk to people, people come out with lots of this anecdote and opinion. And people say, well, you know, we've got too many calls and we don't have enough time to see all these people. And then people say, well, this observation is normal for this person. So, you know, they might have some kind of long-term condition. They might have, you know, awful heart failure and their blood pressure is never very good. So it's always not very good. So why should I respond to this call? Why should I escalate it up to somebody? Why should I respond to this person? And people are saying it's far too sensitive. So then we had to look at that. So we look at it in context of what we are doing. So if we look at the 8 and 9, the red zone part of this, our red zone is registrar bedside review within 20 minutes and then, you know, document the treatment plan and do all of this, because we know that these people are sick. And this is the use of 8 to 9 and then anybody with a single trigger of 3. So we know that this is what we're expecting of people. And we also know that this is exactly what we did with our previous early warning score at this exact same level. So if we could do it then, why can't we do it now? So this is when you start going to the data, and when you've got a big database, you can go and have a look at it. So we went to the data, and then we could see at our NZ early warning score implementation, when we start looking at our red zone activations, suddenly we had this kind of 10-fold increase in red zone activations. And again, we don't have a 10-fold increase in sicker people, we're just using a different tool to measure it. So when we're using that different tool, then we've got to turn around and say, well, what's going on with the red zone, which is making it like this? Again, we can go back to the data. So we were lucky enough, we looked at 6 months worth of data and we looked at all of our calls, and we found that we've got a few people in the red zone and hardly anybody in the orange zone at all. And that really shouldn't happen. We thought that really this graph should look a little bit more like that, because that's our expectation, is that when people deteriorate, you know, and they go through stages of deterioration. So, you know, then we had to look at this a little bit more. So we say, well, what can we do? So let's look at the data a little bit more. Let's look specifically at that red zone, because that's what's causing us our problems. So let's see what's going on. And I know this is a bit difficult to see, but at the end of the day, on each one of these graphs, the columns are the same, but the blue one, the first blue one is number of patients, and this is over 1 month. And the second column is the number of red zone activations. The third one is the number of red zone activations which were caused by an aggregate score of 8 to 9. And then the last column was the number of red zone activations caused by single trigger activations. And we looked in our general medical wards, we looked on our ortho wards, we looked at our neurology, we looked on our surgical, we looked at our cardiology, we looked at our respiratory wards. And then we broke this data down even further and further and further. I'm not going to show you that because it gets a little bit boring and you'll all fall asleep. But essentially, if you go onto the neurology ward, there's lots of people with single triggers because they're not responding very well, because they're, you know, that's pretty surprising. If you go to our cardiology ward, you've got quite a lot of people who've got low blood pressures, or you've got quite a lot of people who've got high or low heart rates. And if you go to our respiratory ward, you've got a lot of people who've got saturations of below 91%. And this is what's causing all of this noise that we've got. But what you can't do now is you can't turn around and say, oh, well, we're just going to disregard the single triggers. Because what harm is that going to do if you do that? You've got the data, so let's go and have a look at the data again. So we went and looked at this data and we said, right, well, let's look at the people who've got a low trigger. So the people with an NZU score of less than 8 with no single trigger. Let's look at the people who've got an NZU score of less than 8, including a spelling mistake and including a single trigger of 3. And then look at the people who have got red-blue triggers, or people who've triggered with an NZU score of greater than 8 or more. So we decided to look at this group. And then we said, well, what are we going to look for? And it's very difficult with data to look at outcomes, because again, we're doing this over a period of a month. This isn't a study of retrospective. We're just pressing buttons and a business analyst is coming back to us with this information. So we looked at the outcomes and we said, well, we're going to go death, because that's reasonably permanent, cardiac arrest and transfer to ICU. So we looked at those as outcomes. And again, this sounds really, really easy. But data is like children cleaning their rooms. So you can look at data and it looks really, really nice and tidy and clean. But if you look closely, you can find they've stuffed everything underneath the bed and they've just moved something from one place to another place. So if I looked at death, the data shows me everybody who died on admission. So they might have got an early warning score when they came through the door, but that early warning score was done when they were just about to die. So it's not a predictor of death, it's the fact that the car that hit them was a predictor of their death. You've got people who've had a cardiac arrest, but it's after their cardiac arrest they improve, but observations after that cardiac arrest, they're having red zone activations, or they're having, so you've got to be able to look at this and start cleaning the data. So you've got to look at all these bits and pieces. With ICU, we've got lots of people who go to ICU post-surgery, because we do lots of cardiothoracic surgery, and then they go back to the wards, and then they become unwell again. So they don't have a red zone and then go to ICU. They go to ICU and then after ICU have a red zone. So you've got to be really careful about looking at the data and how you clean it, because otherwise it tells you a load of rubbish. So we analysed the data. So if we look at the blue column being people who died, and the orange column is cardiac arrest, and the grey column is people who go to ICU. So we looked at that, and we looked at the people with the low triggers. So these are the people who've got a trigger of a score of less than 8, but they don't have a single trigger score within that. And, you know, it's not too bad for those people. And then we looked at this group of the single triggers. So they've got an NZUs of less than 8, but they've got a single trigger within it. And quite a few of these people die. But then we're looking at those single triggers, and another really good study to do would be the people who are more likely to have single triggers are people who are more likely to have lots of comorbidities, so therefore are they more likely to die in hospital? So this is another thing to look at. But at the end of the day, when we actually started looking at the people who score above 8, that's when we're starting to look at all of these people who really are going to deteriorate, and their outcomes are a lot worse. So when we go back to our original question of why aren't we seeing all these people, and then we go to the floor and we look at the floor and they turn around and they say, well, we're not seeing these people because this is normal or it's really, really busy. So we are missing this big group of people at the end because of the alarm fatigue, that 80% of the calls are people in the middle. So what the data starts to tell us now, because we're able to look at that and we're able to look at it quickly, is the fact that should we change our response pathway, and what should we do with that? And then, of course, we go back to the group with the data, we talk to the group with the data, and we say to them, what should we do? So our recommendations at the moment goes through our group. We've got and that clinical governance turns around and says, well, these people are unwell, let's not get rid of the single triggers. So we've de-escalated the single triggers, or we're going to de-escalate the single triggers into our orange zone. So they still get seen promptly, they still get assessed promptly, but we've got a filter before it goes to our registrars who are really busy. But we've got fantastically educated nurses on the ward who can make these decisions. Is this person's oxygen saturations low? Is this part of a plan? Is this known? Because the other thing you can do is you can modify it, or you can write a plan in the notes to say, I expect this, or I can modify the early warning score and then I blunt the system. So we don't really want to blunt the system. And then we go to our chiefs and chairs, so we go to those large people with our data, and they review what we've done, and they've got more expert eyes than us, and they'll turn around and they say yay or nay to what we do. and then we go to that change. And then we start this again. So in 6 months' time, we will do exactly the same process again. But luckily, we've got the tools now, because we've developed the tools through this, so we can just press a button and it will spit the information out. This is a quote from the Gartner Group, who do lots of research on health and health IT. And I think this is really, really true. I think the further we're going down the line now is the information that we have is really, really, really useful. But it's the analytics of that data which then drives us forward and drives us through to improvement. So even though I have a huge data set, and Alex always asks me questions and say, what can I prove with this, what can I prove to that? It does require really good analytics, but at the moment by humans to do that, because we don't have deep learning and we don't have AI to make those decisions. It involves a group of people coming together with, clinical intelligence and acumen to make those decisions. So that's just a little journey through data, and we're just showing what large data sets can do in our environment that we work in. So thank you.